Good morning, and welcome to the New Jersey Legislative Black Caucus Foundation's virtual discussion on reducing health disparities by addressing social determinants of health. I am Sarah Jones, Director of Government Affairs for Horizon Blue Cross Blue Shield of New Jersey, and I serve as a board member of the foundation. The New Jersey Legislative Black Caucus Foundation is a nonprofit corporation created for the purpose of promoting public policy by educating the interactions of the community with legislators and members of government at all levels. This is part 3 of our virtual series, and we have a robust discussion planned with thought leaders in the healthcare field today. But first, I want to take a few minutes to introduce our chair of the foundation, Assemblywoman McKnight. Angela V. McKnight was elected to the New Jersey General Assembly for the 31st Legislative District in 2015. She is the first African-American Assemblywoman elected to the 31st District, which encompasses Bayonne and Jersey City. Assemblywoman McKnight is the chair of the Aging and Senior Services Committee, vice chair of the Women and Children Committee, and a member of the Homeland Security and State Preparedness Committee. She is also Deputy Majority Leader. Assemblywoman McKnight is also the founder and chief executive officer of Angela Cares, an advocacy and support organization for senior citizens, senior caregivers, and the youth. She is also an entrepreneur and a self-published author. She is an advocate for senior care, social justice, cultural fairness in the Black community, and women's health, amongst a number of other important issues affecting New Jerseyans. As a mentor and educator, Assemblywoman McKnight serves as an adjunct faculty member at the New Jersey City University and is an instructor at the Rising Tide Capital Community Business Academy. She holds a BS in business management from the University of Phoenix and has 30 years of experience in customer service and the technology arena. As an activist and social advocate, Assemblywoman McKnight is a board member on several organizations, including the Jersey City Community Charter School, the United Way of Hudson County, and the NJCU Health Sciences Undergraduate Advisory Board. She is also president of the Hudson County Black Caucus. Assemblywoman McKnight has received many honors for her accomplishments and advocacy. Some include, but are not limited to, the United States Senator Robert Menendez 2019 Community Outreach Award and the 2022 Community Impact Award from Trinity Faith Church of Living God. She resides in her hometown of Jersey City, New Jersey, and she's married to her high school sweetheart, Anthony McKnight Sr. They have 2 children, Anaja and Anthony Jr., as well as an amazing 4-year-old grandson named Jordan. With that, I turn the virtual floor over to our chair of the foundation, Assemblywoman McKnight. Thank you.
Good morning. And Sarah, thank you so much for that lovely introduction. And thank you for being part of the New Jersey Legislative Black Caucus Foundation. We appreciate you. I appreciate you. So we are here today for an amazing group of panelists to talk about the Health Equity Diversity Leadership Impact Virtual Series, Part 3. I'm looking forward to this robust conversation. But first, I have a few things that I need to do. I want you all to use the chat to tell me with an emoji how you're feeling about this series. I want to see those emojis just popping up. How are you feeling? What are you looking forward to? Are you excited? Are you happy? Are you sad? Are you anxious? Use one of those emojis to tell us how everyone is doing. And I see the hearts, I see it. So that is good. Just keep them coming, keep them coming. I also want to give praise to our 2 amazing sponsors. Without our sponsors, we would not be here today. So I want to thank Horizon Blue Cross Blue Shield of New Jersey. Thank you so much for being an amazing sponsor. We appreciate you. And also RWJ Barnabas Health. thank you for being a sponsor of this event. We appreciate our sponsors. We know that we cannot do this alone. We have to do this together. So thank you to Horizon Blue Cross Blue Shield of New Jersey and RWJ Barnabas Health to be our sponsors. Now, we are also in partnership with some amazing groups. We have Kane University, we have Rutgers University, the Center for Health Equity and Community Engagement, Montclair State University, NJ Acts for Us, and Rutgers Biomedic and Health Sciences. We are doing this in partnership with all of those amazing entities. Together, we can do so much. So we thank you all for being here with us today, being a sponsor and or a partner, because we need you and we appreciate all of you. So I now have the honor and privilege to introduce our moderator for today. She is a colleague of mine and also a friend, and we also work out in the morning. So I want to introduce Assemblywoman Verlena Reynolds Jackson. Her quote is, "Life's most persistent and urgent question is, what are you doing for others?" And that is by Dr. Martin Luther King Jr. Assemblywoman Verlena Reynolds Jackson is a product of the Trenton Public School System and has obtained an advanced degree from Trenton State College / the College of New Jersey, Central Michigan University. Her career as a social worker coupled with a commitment to public service led her to the elected position of East Ward Councilwoman and Council Vice President, where she legislated laws for the city of Trenton. Assemblywoman Reynolds Jackson proudly served 7.5 years on city council before being elected to fill the vacant New Jersey Assembly seat in the 15th Legislative District. Ms. Reynolds Jackson is currently serving her 3rd term in New Jersey Assembly and has ascended to senior leadership, where she serves as a constituent outreach chair and vice chairwoman of the Assembly Commerce and Economic Development Committee. She is a member of the Assembly Budget Committee. Thank you so much for being on that Budget Committee. The Assembly Higher Education Committee, the Joint Committee on Public Service, and the Joint Committee on Economic Justice and Equal Employment. The Assemblywoman also serves as a commissioner on the State of New Jersey Martin Luther King Jr. Commission, the Amistad Commission, and is co-vice chair of the New Jersey Legislative Black Caucus. Since graduating from the college, the Assemblywoman has continued her education through New Jersey Redevelopment Authority and Rutgers University. For the past 10 years, Verlena Reynolds Jackson has been committed to serving her constituents through public service. She has achieved great satisfaction working with various populations, including her neighbors, the homeless, elderly, children, and people with disabilities. Her work has focused on social justice, enforcing business and landlord responsibility, environmental protection, and demanding accountability for students. Verlena resides in the city of Trenton with her husband, wonderful husband, Lorenzo Jackson. She has membership. She's a Delta Sigma Theta sorority. She's on the League of Women's Voters, Women's Political Caucus of New Jersey, the College of New Jersey Alumni Association Board, and YWCA of Princeton Board of Directors. Her education, she has a Master's of Science in Administration, Central Michigan University, Bachelor's of Art, Sociology, Trenton State College, the College of New Jersey, and State of New Jersey Certified Municipal Finance Officer. Without further ado, I want to pass the baton over to our great moderator for today's session, Assemblywoman Verlena Reynolds Jackson.
Thank you so much. Thank you, thank you, thank you. I thought I gave you the short version. I didn't mean for it to go on and on and on, but thank you so much. I'm excited to be here today. Thank you to all of the panelists and our partners. And I want to thank you again. Thank you so much to each of you for tuning in today for the Health Series seminar hosted by the New Jersey Legislative Black Caucus Foundation. This is the third of a four-part series addressing health equity and diversity. Today's topic is on social determinants of health. And so I thought that this would be a great idea to define what we're going to be talking about in terms of defining social determinants of health to gain a better understanding of the topic. But before I do that, we have some wonderful panelists, and I want to introduce them as well. So let me do this. Let me introduce Dr. Denise Rogers. Dr. Denise Rogers is currently the Vice Chancellor for Interprofessional Programs at Rutgers Biomedical and Health Sciences. She is also a professor in the Department of Family Medicine and Community Health at Robert Wood Johnson Medical School. Prior to her appointment as Vice Chancellor, Dr. Rogers was the Executive Vice President for Academic and Clinical Affairs at the University of Medicine and Dentistry of New Jersey from 2006 to 2013. She has also served as the fifth and final president for the University of Medicine and Dentistry. Dr. Rogers has devoted much of her career to serving underserved patients and communities. She is currently chair of the Greater Newark Health Coalition. She chairs the steering committee for the Believe in a Healthy Newark initiative, and she's currently ended her tenure as the chair of the Newark Homeless Commission. Dr. Rogers is also the principal investigator for the 4-year Rutgers Equity in Action for Community Health REACH grant funded by by Robert Wood Johnson Foundation in 2021. So I'd like to welcome Dr. Rogers to our panel. And I've served with Dr. Rogers on many panels, and I love it because she speaks energetically and she asks questions. So I'm very excited to have you on our panel today. I'm going to introduce Dr. Damali Campbell or Parji. Dr. Campbell is board certified in obstetrics, gynecology, and addiction medicine. She is dedicated her practice to improving the care for women in underserved areas. Since her graduation from residency training, she worked in several New Jersey urban areas, including Jersey City, Patterson, and Newark. Her interests include health, broadening health education and cancer prevention, breastfeeding, risk reduction for maternal morbidity and mortality, which has included focusing on addressing social determinants of health. She also sees women who are pregnant with addiction and manage both the pregnancy and the medical aspects of their addiction. Welcome, Dr. Campbell. I've also worked with Dr. Campbell when I first came into the assembly. She was a part of the panel discussion with the First Lady, and I'll never forget that. Thank you for always being there, not just then, but continuing through your career. We appreciate your voice being at the table. Next, I'm going to introduce Ileana Griffith. Ileana has always utilized life and work experience effectively to lead effective leader during her career at Horizon. By utilizing her professional experience in sales and project management, she is able to effectively align Horizon's neighbors in health goals and daily operational workflows to Horizon's enterprise goals of addressing healthcare equities and health disparities to improve health outcomes. Ileana, prior to her role as a certified project manager, was a part of Horizon's enterprise project management office and led the implementation of numerous medical cost-saving projects. And I'd like to welcome Ileana to the program. Next, we have Andrew Thomas. Andrew started his health career as a patient care technician at Robert Wood Johnson Hamilton 30 years ago. He earned his MSN from Drexel University in Philadelphia and briefly worked as an acute care nurse practitioner for a private cardiology practice in Hamilton, New Jersey. In 2011, Andrew joined the team of Robert Wood Johnson University Hospital, taking different leadership roles, initially starting as an assistant director of hospital-based practitioners and then director of transition and care coordination, where he led multiple hospital initiatives. As a Lean Six Sigma Black Belt, Andrew used his skills to create innovative programs and community partnerships to provide safe, effective, and timely care for patients in and out of the hospitals. Welcome, Andrew, to the panel. Now, this woman, next up, Assemblywoman Shavonda Sumter of the 35th Legislative District, really needs no introduction. She is our chair of the Legislative Black Caucus, and she's also the chair of the Community Development Affairs. She is passionate about social justice, maternal health, and civic engagement. And so I'm cutting all of hers short because we all know the fabulous, the wonderful, the unapologetically speaking woman, Shavonda Sumter, Assemblywoman. Welcome, welcome, welcome. So I'm now, because initially I started talking about setting the table, right? There is different types of social determinants of health. And we all agreed that the best way to define it was to use the World Health Organization's definition. And so they say the World Health Organization defines social determinants of health as non-medical factors that influence health outcomes. They are the conditions in which people are born, grow, work, live, and age. They are a wide set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies, development agendas, social norms, social policies, and political systems. The social determinants have an important influence on health inequities, the unfair and avoidable differences in health status seen within and between countries. In countries with different economic levels of income, health and illnesses follow a social angle. Usually, the lower the social economic position, the worse the health outcomes are. So the following slide provides examples of social determinants of health, which can influence health equity in positive and negative ways. There are some that are social income. We have income, whether there's high or low, our social status, our urban, our suburban, our prestige or non-prestige. We have education, whether you're college educated or tech school certifications. We have literacy, when we talk about our early childhood development, reading on par at grade level. We talk about employment, part-time, full-time, professional. What are your working conditions like? Food insecurities, housing, basic amenities, and the environment. We talked about the early childhood development, social inclusion and non-discrimination, structural conflicts and conflicts of interest, access to affordable and quality healthcare services are all very, very important. So as we set the table here and we begin to open up the questions, I want you to know that a lot of research has shown that social determinants are more important than health outcomes and lifestyles choices, which influences our health. For example, numerous studies suggest that social determinants account for between 30 and 55% of health outcomes. And so now that we've set the table, let's move on to some of our questions that we have so we can begin to open up the discussion. So the first question we have is, what is health equity and why should we focus on this issue? And I'm going to start with Dr. Rogers and Dr. Campbell. If you could just talk to us a little bit about why this topic is so important and it should be inclusive of the series that we're going through now. Dr. Rogers?
Thank you, Assemblywoman. I like to use the Robert Wood Johnson Foundation definition of health equity, which is that everyone has a fair and just opportunity to be as healthy as possible. And in order to do that, we have to be willing to address social determinants of health. I also think it important to remind all of us that in this country and in this state, we still have a very long way to go before we achieve health equity, as there remain significant disparities, both in the levels of illness and in rates of death, particularly in African American and to a lesser extent in Latino populations as well.
Awesome. Thank you.
And so I would just add that, you know, health equity is giving each person what they need to achieve the optimal outcome. And so as a provider of clinical care, it's really important to focus on health equity, because as a provider, really what I want is for the best outcome for each individual that I'm seeing. And so if that is the finish line that I want to get to, if I focus on that prize, what is it that I need to give each person to be able to get that optimal outcome?
Thank you. I feel like I also, you know, we talk about social determinants and we talk about health disparities. Dr. Rogers, how are social determinants of health related to health disparities?
Well, I think in very simplistic terms, one of the ways for us to think about it is it's bad for your health to be homeless. It's bad for your health to have inadequate food. It's bad for your health to be poorly educated. We know in this country, for example, that a man who drops out of high school will, on average, live 9 years less than a man who graduates from college, and the disparity for women is 8 years. We know that men in the richest top 10% of income in this country will, on average, live 15 years longer than men in the bottom 10%. And so it's very clear that, unfortunately, to be poor in America often means to be in much poorer health in America, and therefore to suffer from premature death and an increased burden of illness.
Thank you. Assemblywoman Sumter, in your role as the president and CEO of Children's Aid and Family Services, how would you define in your space social determinants of health and health disparities?
Thank you, Assemblywoman Reynolds-Jackson, and to Dr. Rogers and Dr. Campbell. I like that we make it plain. One of the things that we struggle with is using these terms as sound bites of social equity, health determinants. They sound great, but how do we put them into action? In my role as CEO of Children's Aid and Family Services, we're strengthening families. We struggle when we don't have sufficient housing, and we struggle when we don't have transportation to get to a healthcare appointment. We struggle when we don't have healthcare practitioners within the communities in which our clients that we serve live, which also impacts the health and well-being of the entire family. If we put a lens on women's health and the breakdown of a woman's physical health, let alone mental health, it impacts the entire family. So really creating opportunities where we can learn more, improve upon access, and partner with providers to get this information out in the community has been a priority of my legislative career and my life's work. So thank you for that question, Assemblywoman Reynolds-Jackson.
You're welcome. Thank you. To Dr. Campbell. Dr. Campbell, practitioner in healthcare institutions, how can patients establish a trust in healthcare systems and increase preventative care? And then I think that's a great question also for Andrew and Eliana.
Thank you. I think, as Dr. Rogers pointed out, on many levels, we have a lot of work to do. One of the hats that I wear is as the president of the National Medical Association, the New Jersey chapter, and organizations like the New Jersey chapter of the National Medical Association, much like the Legislative Black Caucus, are doctors who are traditionally a part of these communities. They understand we are members that live and work and pray alongside community members. And so there has been this long-standing relationship and trust. Healthcare has changed over time. And so a lot of doctors that are coming out of school these days are not setting up private practices in communities. We are working in group practices. We're working in institutions, as I do today, but we still live and work in the community. And so we do have an understanding of what patients are going through, and we need to bring that understanding into practice.
I want to just double down a little bit on that, because you specifically chose to practice where you are. And I think you talked about it, where there is the option, the new doctors that are coming out that can choose to go else places. Assemblywoman Sumter, chair of the community development, what can we do as legislators to be able to attract more to our urban centers? What can we do?
So a couple of things that we have worked on. And when we talk about inequities, and Dr. Campbell, you were gracious, you didn't share the origin of the New Jersey Medical Association, where you could not be members of the New Jersey Medical Society. So really had to form your own association to support doctors in our community. New Jersey is not exempt from the hands of disparity, and that's why we're here today. So working in the legislature, we work to, in an emboldened fashion, Senator Rice fashion, to highlight these inequities and the needs of our community, being sure that graduate medical education credits and funds go into institutions that support our folks going into training programs and having seats in the states for them to attend residency, all important. Fighting, and Dr. Rogers, you were a part of this, to be sure that there was room in the schools for them to practice in the great state of New Jersey. We were #1 for 2 years straight, coming through a pandemic, for the best primary educations in the country. But yet when it comes time for higher education, we struggle with paying for it. So supporting things like the Garden State Equality programs for community college to higher education college to being sure that we're providing some of those funding sources for our folks to be able to go to school and earn a living are all passions that we fight for daily, let alone the housing pieces that we work on, which also prove to be a barrier. And the list is long, but I say this, when we have sessions such as this, it gives me hope and courage, because that's the battle that we're fighting every day.
Thank you. I just didn't want to glance over that piece, right? That's a very important piece. And Ileana and Andrew, can you tell us, how are you building trust in the communities now through your institutions? Ileana?
Sure. Thank you so much. I'm so happy to be on this panel this morning. I'm with Horizon Blue Cross Blue Shield as an implementation manager, and I work for Neighbors in Health, which is a SDOH program where we work directly with our members through partnerships with hospitals and healthcare systems. So during the pandemic, when we launched, we were right there on the front lines providing food and eliminating or mitigating some of the social determinant issues that occurred with COVID. So we are making a direct impact for our members. So getting back to the exact question, how do we build trust? We are out there with the clergy, right? It's a team effort. It's not just Horizon doing the work. So we are looking and recruiting providers of diversity so that they represent the community. We are out there with clergy in partnership to say, hey, we have to walk the talk, right? We can't just talk about it. We have to be about it. And we're out in the community through our partnerships, through our community programs, in the colleges and medical schools, getting providers to try and even that playing field and making sure that when I go to the doctor, I'm able to get that female doctor or that Hispanic doctor or that Black doctor, so that when I go there, I'm more comfortable. Maybe I'm more able to ask questions, right? That's part of it. We know a lot of members go to medical facilities and they come away just as confused and not knowing what they need to do. So it's working as a team, and it's talking about the good things that providers do, right? The world is not always negative, although we do focus on the negative, but sharing those positive experiences and trying to reduce people's trauma around physicians and mistrust, and just doing the best that we can. It's a slow but steady process.
Thank you. I agree. I know I see Horizon out at a lot of our community events, or especially recently, our back to school drives. We're trying to make sure that the children are immunized, making sure that families can take their blood pressure, just simple things, those soft touches to try to get them in the door. So I appreciate that as well. Andrew, how would you say your organization, how are they building trust in the community?
Well, I believe the COVID pandemic actually highlighted the effect of mistrust in the healthcare system, because we saw how difficult it was for us to actually get brown and Black people vaccinated. We saw how difficult it was for not just the organization, for the state, for the nation to actually get people to understand the importance of testing for COVID. We saw how difficult it was for our employees, the Black and brown employees, to actually get vaccinated. So what we did is was actually start thinking about, how do we develop better partnerships? We as an organization are serious about being an anchor institution in most of the communities that we served. A couple of years ago, we actually put as part of our mission statement to not only treat clinical conditions, but also deal with social determinants of health. So we have social determinants of health in our mission statement. But I think fundamentally what we have to do as practitioners is do simple skills in communications. We have to communicate clearly. There is no reason why we cannot communicate in a way to build trust in any relationship. We have to. We have to listen well. One of the best ways to serve our patient is to listen to them, right? Listen to their questions, their problems, and their concerns. We have to be available. Building trust is an ongoing process. This is not going to be solved overnight, especially in the healthcare field. With all the history that we have, with mistrust in the healthcare space. And most importantly, we have to follow through and hold ourselves accountable. We have to hold ourselves accountable that we have to be responsible as a healthcare organization to build that trust. We cannot expect the patients to actually come back and just for the sake of believing in us, trust us with all the history of mistrust that we have. So I think those are things that we should actually put in place, those fundamental things.
Can I add one thing? Through our Neighbors in Health program, our goal is to help the member help themselves, right? So we want the member to stand on their own 2 feet. So we have a CHW, a community health worker, that works with the member on their goals. So if they're going to, when we try to make sure that all of our members have a PCP or specialist to go to before they graduate from our program. So we like to prepare the member. We give them material, we give them questions, we give them documents that they can write down their questions on. We even have the community health worker go with them to the doctor's appointment to be that second set of ears or eyes. It's more complicated when English is not their first language. So some of our CHWs are multilingual and they're able to interpret and help that member really get out the value out of that visit that they really, really need to. Because if they need to understand their prescription or when to come back, we want to make sure that they leave that office with the information. So it's not only the providers, but we have to do the work on the member side as well. And that's what Neighbors in Health is doing.
Thank you so much for that. Andrew, you bring up a very both of you valuable part. COVID absolutely ripped the veil off of the health disparities that we're having here. And I have a question for you, Dr. Rogers. Knowing that with COVID and how it magnified the disparities, what are some of the structural issues that must be addressed to begin building healthcare systems to make them more equitable?
Thank you, Assemblywoman Reynolds Jackson. Before I answer that question, actually, though, I have to put an acknowledgement into the success, actually, that we had in New Jersey in partnering with communities to get people to get vaccinated for COVID. Because at the beginning of the pandemic, there was tremendous mistrust. And many of us and many people involved in this webinar were involved in partnering with faith-based and community-based organizations and FQHCs. And so the disparity has actually decreased. And nationally, in polls, it's actually whites, typically white Republicans, who are least likely now to want to be vaccinated. And so I don't want to lose that opportunity to point out that sometimes we actually do have victories when we do it right. And a shout out to the Department of Health, because at the state level, because they really funneled monies into these communities in order to help us with those activities.
I just wanted to chime in, you're right. And even translating the information into other languages, right? That was huge. That was a huge part. And I don't think I've seen it at that volume before. So thank you for bringing that up.
Yeah, no, it's true. The other thing I'm going to say is one of my favorite things, I will confess, about being on a webinar with you three incredibly dynamic and wonderful Assemblywomen, is that I am given an opportunity to actually give you a bit of a challenge. And one of the challenges I would like to offer to you is that one of the major things that we need to be looking at in New Jersey is providing universal access to healthcare for everyone. Hawaii's done it, Massachusetts has done it, California in parts has done it. When you look at structural barriers to healthcare, obviously the clearest obstacle is if I don't have insurance, right? And the notion in this country that we pair insurance with employment. So if you take COVID, I get so sick with COVID that I'm out for a period of time and I lose my job. And at the same time I lose my job, I then lose my access to healthcare. What did that mean? That meant very often, tragically, people who were sick kept going to work. What that then meant was that they infected other people, and we sort of had this terrible cascading effect. And so thank you all for giving me the opportunity to, in whatever way I can possibly do it, I would love to partner with you, but to figure out how New Jersey becomes one of these states where everyone has access to high quality healthcare. I think the other thing that has just jumped out at us as a result of the pandemic is we need better access to mental health services, and we need access. So everybody agrees we need access to mental health services. We just can't figure out how to do it. We can figure out how to do it. I mean, with partnerships between providers, insurers, you and the legislature, we can figure out how to do this. But we also need access to dental services, because having bad dentition, having cavities and missing teeth is a huge obstacle to good health, and we don't talk about that enough as well. Obviously, I have a long list that I could go on and on about. I will stop now so that others can come in, but please let me partner with you around how we get universal access to healthcare for everybody in New Jersey.
I love it. Dr. Campbell, please.
Well, I just wanted to piggyback on something that Andrew did bring up. You know, it's not only our words, it's also about our body language is so important. And we know the healthcare shortages, the staffing, and, but when we're rushing, patients can feel that. And so it's not only important what we say, how we say it, but also our body language. And there is literature to support that when we sit down, when we look eye level at patients, we don't necessarily spend any more time, but they feel that they are heard better. It's important that we are asking about patients' preferences and acknowledging, who are the influencers in our patients' lives, because oftentimes that's where the healthcare decisions are being made. And in many culturally, for many patients, that doesn't just lie with that one patient. It may lie with their mom, with their grandma, with their aunties, with that village that has helped to get them where they are. And we have to acknowledge that.
Yeah, thank you. Thank you. Ileana, I was coming to you next. Go ahead, chime in.
So within that regard, our organization Horizon is working with Robert Wood Johnson to do a implicit bias training for our providers, right? So mixed into that, making sure that you're making eye contact and the language is correct and the perception is correct. How do you know what you don't know, right? So how do you know that you're not treating that person unconsciously in a manner that's not appreciated? So we're putting all of our providers through that training, that exercise to hope, and it will take time, right? I don't know what I don't know. I could tell you I'm not a biased person, but no one's ever asked me the question or sat down with me and said, well, have you thought about things this way? Have you thought about things that way? And you go, oh, no, I didn't. Did I know that was offensive to you in the way that I said it? No, I didn't. So that's what Horizon is committed to doing, to try and alleviate some of this provider mistrust, misunderstanding, inequity. So it's just one of many steps that Horizon is taking.
Thank you. And then Ileana, I did want you and Andrew to lean in a little bit on the health, the mental health, now that it's getting all the attention and the resources that have been, way overdue. Can you talk about Horizon and St. Barnabas, what they're doing on the mental health aspect? So,
Mr. Thomas, I can give you the floor before I begin.
Okay, perfect. And I really like to go back and just piggyback on that conversation about mistrust, because I've had this conversation quite recently with somebody telling me that when we mentioned about the Tuskegee syphilis study, they were saying, oh, that was a long time ago. So I really like to, for the sake of just telling the audience that was not really, it was not too long ago. This study was 1932 to 1972. It lasted for 40 years. And it was in the United States, right? An example often cited, this was public health services official, not a quack doctor somewhere. 600 Black men, not 2 Black men, right, were in that study. And, they died of syphilis. So we can understand where some of this mistrust is coming from. So once we bring that study up, usually our colleagues say, oh, that's a long time ago. We hear that with, anything that we bring up, the pushback we get is a long time ago. But really, it's not too long ago, right? I mean, I was born during that time, that those study was going on. So it's not really quite too long ago. For mental health issue, to answer the question, we are actually doing a lot in that space currently. We have the peer recovery group. Peer recovery group is like a rapid response team. A patient comes into the emergency room with a mental health issue. We have rapid response team that can actually look at the patient, and usually we have providers who have gone through maybe substance abuse issue, who have lived lives of that same particular kind of patient. So they can talk to that patient and relate to the patient, all in the aspect of gaining trust of the patient. We're partnering greatly with University Behavioral Health division at Rutgers University, and they cover the whole state. As an organization, we have footprint on really most of the counties in the state. So we're able to see people, and as a big organization, we're really able to share information with our EPIC system, the new EHR system, which has transformed the way we share information, and that has significantly helped, especially when it comes to mental health issue. A lot of the information get lost in translation. A lot of the information get lost. Somebody has a mental health issue, it's highly protected. So your providers don't see that, especially your medical providers, right? We tend not to see or glaze over what medications they're on. And, somebody who has history of say, depression, might be on medication. They don't want to talk about it.
Mm-hmm.
So because we don't have those records, we put them on other medications that can counteract the effect or interact with those medications. So we have this trouble. So our EHR, medical record system is highly, highly valuable and really, really helpful. Thank you.
Thank you, Andrew.
So I'll add on to that. For Horizon, maybe about 3 years ago, we brought back in-house our behavioral health, mental health processes. It was outsourced prior to that. And there's been such an increase and improvement in the processes that we have around behavioral health and mental health. So I think one of the first things is that our company is trying to, I don't say normalize, but destigmatize mental health, right? We talk about it in employee meetings, we go through trainings, you see the commercials on TV. So we try to take it out of the shadows, because we all, whether it's severe or not severe, we all have issues that we struggle with, right? It's making sure that people know that the help is out there with whatever you need or with whatever you're struggling with. We encourage EAP for our members or any kind of employee assistance program, our members and our employees. So we don't distinguish between, our members have this and our employees don't have that. But our behavioral health, we have about 8,000 providers, and we've increased providers by 40% since 2020, right? And we're looking at all sorts of providers, whether you're Latin, whether you're Black, whatever you are, to try and cut across the board to have a provider that suits our individual membership and community. But in addition to that, we kind of modernized, right? So it's, with COVID, everything became telehealth. Well, that hasn't gone away. If you need help immediately, there is an option for telehealth. It may not suit you. There's also an option for group therapy. There are many virtual tools that people can utilize. Maybe they just need like someone to talk to on the phone, right? There's that. Or maybe there's some sort of psychological test, minimal psychological test that they can take that might give them some information. So we have a website, we have digital health tools, we have additional care and navigation for members so that we can do like more of a wraparound coordinated servicing with them. And also our CHWs are involved, not from a mental health standpoint, but if there are SDOH needs that are prohibiting that person from getting the mental health that they need, we can help solve that. A lot of our members, can't make their appointments simply because they don't have the bus money to get there, or they don't have the money to park the car, or they don't have a car. So coupled with our mental health providers and our CHW from our Neighbors in Health program, we are able to get that person on the right road. There's 24/7 peer support. I mean, everything that you can think of, we are making it accessible for our members and our employees.
Thank you for that. And I just wanted to add, we're making it the norm, right? You talked about demystifying it, stop making it like this is this other thing. I know here at my organization, we do walks all the time, whether it's for breast cancer, whether it's for March of Dimes, but now we're doing walks for mental health. And so I'm like, yes, this is part of making it normal, because everybody goes ups and downs. Everybody goes home saying, I'm stressed out from work, and it's, some may be joking, but some is real. And so how do you deal with that at work? And so I think that's part of the culture that many organizations are starting to build upon, which is a good thing. And so I thank you for interjecting all that. I see Assemblywoman Sumter, you about to jump out of your seat over there. You want to add?
I am, because, this part is my passion. A couple of things that's good that came out of the pandemic. We have been resistant as a state to telemedicine for mental health. The pandemic fast forward us into that space, and we saw an increase in people actually showing up for their appointments. In fact, new clinicians, whether you're a licensed clinical social worker, a licensed professional counselor, a psychologist, they don't have room in the schedules. Literally, the demand is great. So really, as a legislature, we're working to make sure that it stays telehealth with the reimbursement at the level of an in-person visit, because it's still the provider's time that they're using to provide the services, which is critical. We also need to partner a little closely with schools, and I saw Sheila Caldwell inbox us regarding the school-based mental health system and the Medicaid-based mental health system. We work hard for equity, for mental health and physical health, but we're still not there with access, as we heard all of the other panelists share. So really, I'm hoping as a legislature that we move forward with making sure that we create additional access, as we not only need it for the adult system, but also for the children's system, and really destigmatize it and not just have the signs of green saying we, support mental health, but access to resources and fair payment and reimbursement for providers. And to Mr. Thomas' point on the electronic medical record and having a system where they can access it. We lost community-based nonprofit providers in the pandemic who could not afford to reopen or have providers who worked there who left the field. So we're really going to have to deal with that. The urgency of now is there for that space to be sure that we have the depth of services that are needed for persons in need.
Thank you. Dr. Campbell, you want to interject as well?
So I wanted to go back to something that you mentioned at the top of the hour. How does the health equity and health disparities? So, someone talked about diabetes. And if you think about two patients who might have diabetes, one who lives in an area where there's access to healthy fruits and vegetables and they have easy access to that, and one who doesn't, one who may have challenges in getting their medication, and one who doesn't have challenges, one person who may have a safe space to exercise, which is part of the treatment, or controlling the blood sugar, the education that's needed, the eyesight that's needed to pull up the insulin and make sure that you're getting the right amount. All of those things go into the controlling of that illness. And so you can imagine, and we always compare ourselves to other countries. And, the United States is one of the richest countries. We spend so much money in healthcare. But why do we see that we have these poor outcomes? And we it's not that other countries don't have disparities, but they do have disparities. And as was mentioned, it's tied to poverty. And so, but you can imagine that if you live in a neighborhood and you don't have access to some of these things, if it's hard for you to get transportation. So this is why these social determinants of health have to be addressed in order to get to the better health outcomes.
Yeah. Thank you. Thank you for that. Dr. Rogers?
Yeah, thank you. I want to go back to mental health for just a second. And you all are never going to invite me to do this again because I have another recommendation for you as Assemblywomen. Because I think as a family physician, I'm as interested in promoting good mental health as I am for making sure there's treatment for those who are suffering from poor mental health. And one of the things we know can work is mindfulness and exercise. They really significantly reduce stress. And mindfulness can be meditation, it can be quiet prayer. I mean, there are a variety of ways that mindfulness can be practiced. It isn't any sort of specific religion based. However, one of the challenges we have in New Jersey is that school children very often don't have an opportunity to either of these things. We're so concerned about how children perform on standardized tests that we, take what in my day we used to call gym class, right? There's like 10 minutes of play that we give kids. It's not enough. We don't bring mindfulness into schools. These are skills that we need to be teaching all of our children. And there's plenty of evidence actually that shows that if you reintroduce exercise into the school day, children will actually perform better. and you guys can help with this. And so just one more on my list for helping with some of these critical issues.
No, you're right.
I might just add one more thing,
Yes.
in regards to just to bring in the pregnancy piece and obstetrical care. It's such a huge issue for women and families and pregnant persons to think about the mental health issues for the entire family. And we have to talk a little bit about social media because, what families should expect that 2 days after they give birth, it's not going to be all, roses and glory, maybe, that's okay. But we have to prepare our families.
Great point. Andrew?
Yes. So, Dr. Rogers, I really wanted to add on what Dr. Rogers said. It is so sad that even as we cut back on exercise in the schools, when the kids come home, what do they play with? They don't play outside, right? They're on their Nintendos, their PlayStations, and what have you at home. So that actually creates a significant problem. And I don't believe that as a society, we have, we're at a space where we're ready to tackle the effects of that. We see obesity, obesity is one of the leading health indicators in New Jersey. But I think, that exercise is a key piece that we really need to talk about. But I hate to take us back, but I really want to tie three things together. We've given a very good definition of health equity. We've given a very good definition of social determinants of health. Another very important thing that we talked about is health disparity. So let me, if you don't mind, I just need to give a good definition of health disparity and how I believe all these three tie together. So health disparities are really the higher burden of illness, injury, disability, or even mortality that one group of population experience relative to another. So there's that disparity. So addressing social determinants of health is what we need to eliminate health disparity. And we can only achieve health equity when we eliminate this health disparity. So social determinants of health we address, it eliminates health disparity, and that lets us achieve health equity. So that's how all three are tied together. I just wanted to add that.
Yes, thank you. And we're going to get ready to wrap up too, but I do have a that came from the chat that talks about how can anyone speak to the disparity in organ donors and recipients. I know I recently did a blood drive with the American Red Cross. My goal was 50 people, but they told me that's like above and beyond. They usually get between 20, maybe 25. Well, I did 30, but I'm telling you, I had to say I had to go to the baseline. So when I tell you it was hard, but the good thing was the nurses that were there said we never had this many Black and brown people at one time give. This was specifically for sickle cell as well. But it was really, really good. And I don't know if either one of you want to be able to talk about just, organ donors and recipients in that space.
Yeah, I will start. So organ donation, blood transfusion, donation of blood product is and has been a challenge for organizations like ours, especially from people of color, Black and brown people. And that all stems from the mistrust in health system, one. And also just actually getting people, if somebody has food insecurity, has transportation issue, had other things that they have to deal with, which is higher in minority communities, it's really understandable that, to get them to come, donate blood or to even talk about blood organ donation is very, very difficult. So the social determinants of health, developing the trust in our community is key. And I think one space that we really have to use that we as organizations, especially an organization, is not using as much as we should is partnership with faith-based organization. Partnership with our churches, because that is the way we can get trust. We can start building trust. It's not going to build trust completely, but we can start building trust in that space. And also, I think it's Dr. Campbell or Dr. Rogers mentioned that, or somebody, we really have to try as best as possible to start increasing the color of practitioners and providers that we have. You know, you go to somebody, you know, that does not look like me, it's difficult for me to trust in that particular space. So the only way we can get more providers is also, you know, be intentional about how we can help Black and brown people get into medical school, succeed in medical school, and practice in our most difficult neighborhoods.
Yeah.
So I think that, first of all, I want to just pick up very briefly on something that Mr. Thomas just said related to what providers look like. And that's the whole range, by the way. It isn't just physicians, it's nurses, it's respiratory therapists, it's physical therapists, it's the whole range. But that's not the solution, because there just aren't enough of us. And quite frankly, not only are there just not enough of us, but as an African-American physician, I don't want to be told that the only patients I can take care of are African-American patients. There are actually benefits of people who are not African-American coming to see an African-American physician, because it helps to sort of have us all understand that quality care can be delivered by anyone. And so part of the goal, don't get me wrong, I'm in health professions education. It's my job. I very much want more diversity, but I don't want the burden to be on clinicians of color to have to solve this problem. Because the more we feed into that narrative, it lets our white brethren and sisters kind of say, well, you know, they're just going to hire more, and so I don't have to worry about my bias and all of that other stuff. And so I want us to walk very carefully with that. The other thing I need to very much acknowledge is there are a significant number of majority providers, clinicians, nurse practitioners, PTs alike, who are very committed to working with communities of color. And so this, and quite frankly, there's some people of color who aren't as committed to working with communities of color. And we know on the national stage about some Black folks who aren't particularly committed to Black folks. And so, you know, this is a very careful path we need to walk when we talk, because I also don't want to send a message to the larger public that if I walk into a room and there's a white provider in there, that automatically I can't trust that person. That is not my experience, actually. I think, unfortunately, there are too many that are not adequately trained, as Ileana and Horizon are trying to do. But it isn't that every single white provider is a culturally incompetent and insensitive provider. And so that's the hard part of this conversation we also need to have.
No, I agree with you, Dr. Rogers. I think those are the partnerships that we talk about, right? Being able to have those cross conversations, and it shouldn't be a burden on one and not the other. But, you know, we're all human beings and we should be all trying to uplift each other. You know, I think about some of those, we have a high stroke rate in our capital city. But I think about those social determinants of health. You know, how do we get fresh fruits and vegetables? How do we get, you know, access to go outside for a walk without in fear of? But the systems created a stroke center. And so we're really not addressing the root cause, but we have, you know, great medical attention for when you get there. So, you know, we have a lot of work to do around that. But this is a partnership. So I want to be able to save lives, but I want to prevent us from ever getting there in the first place. And I think we should wrap up now. And so I'm going to turn it over to our esteemed Assemblywoman Sumter. If you would like to close us out, or if our panelists, let me push pause. If our panelists, you know, we went back and forth and up and down and all around, but I know we all wanted add something before we end, right? Because I do. When I hang up today, I'm going like, Dad, I should have said this, or I should have said that. So let me start with you, Ileana. If you have anything, closing remarks that you'd like to give today.
Well, this has been exceptional. I was nervous coming in, but I thought it was wonderful, a wonderful panel, and I've enjoyed myself. The only other thing I wanted to bring up was that Horizon is really focused on maternal child health and decreasing the number of diverse women who die in childbirth. Yes. We have a lot of commitments. You know, we are looking at the racial disparities associated with it. We're working in community with partner engagement, collecting data, looking at certain providers who may have a higher level of morbidity or, you know, maternal health deaths. We're looking to influence policy. So there's a 5-pronged approach. We are looking at bias training, access to midwives. And for Medicaid, in 2020, we implemented the use of doulas at home and in hospital. So those are concrete steps that are being taken by Horizon around the maternal health child disparity that we're seeing. And I thank you.
We can have a whole panel on that. I do. I got pages and pages of questions here. I apologize. Other things, but we're going to come back. We still have part 4. We still got one. So we're going to come back. That could be a whole conversation, right, Dr. Campbell?
Definitely.
One question. We can't just do that maternal health, and we can't do that in one question.
Yeah, it's hard, but you know, I would be remiss as an OBGYN if I didn't mention,
absolutely,
you know, the elephant in the room. As we talk about social determinants of health, it does address for some women some of the issues in terms of our poor maternal health outcomes. But we do know the data does show that college educated Black women are still 5 times more likely to suffer from preterm birth and maternal complications. College educated Black women. And so really, there is no silver bullet. There is no one thing that we can do that's going to change that number. But I think 2 things that we have to acknowledge, and that is 1, the implicit bias training that folks have brought up, and that has to be rolled out, not just among providers, because there are many people that touch the patient even before they get to the provider, from the security guard when they walk in to the admitting clerk when they ask what clinic do you go to instead of who is your provider or who is your doctor, to the nursing staff. And you know, we also have to think about the concept of weathering, and that's the constant stress of racism that leads to premature biological aging and poor health outcomes that we see in many people of color. And I think those 2 things, because as a Black woman myself, thinking about, you know, not wanting to bother anybody, not wanting to, you know, the stress of the work that I'm doing, but knowing that, you know, I don't want to seem weak, I don't want to ask for help, those type of things. So we have to acknowledge that. We have to offer help to our colleagues where we can, but we have to address those 2 issues in addition, if we want to change the maternal health outcomes specifically. Thank you.
Absolutely. Thank you. Let me acknowledge all of the people that are on the call. Thank you to the participants. Thank you for all the questions that we have in the chat. And I know I keep getting questions about our youth and how we can get this information to them. I think it's really, really important that we do. And Assemblywoman Sumter, if you could just, in your closing remarks, if you want to address that, how do we get this information to our youth and into our schools?
A couple of things, and thank you. The thing that I love about these virtual series that we uplifted through the foundation is that we have experts from our community who speak with transparency, who break down these terms that we have come up with and really share with us what they mean. And it's a trusted source. We heard that early on. Our panelists are also being queried and our guests on what topics they would like to hear next. So please be sure to complete that survey. But also just knowing that we're committed to this work as a Legislative Black Caucus and the Foundation, working on curriculum. We don't shy away from, even though it's a very contentious time right now, but we do know the value of education. We do know that our communities want to hear from a trusted source, especially first generation here in the States, let alone my family who, migrated from South Carolina. I can't tell you the calls that I received on, is it safe to get vaccinated? Can I help them get vaccinated? And was shocked and honored at the same time to be able to do this and able to bring true trusted partners who are skilled, experienced, can interpret the data, which is highly complex, that people are finding on the internet from reliable sources. So this won't be the last time that we convene. To our panelists, Dr. Rogers, we take the homework serious.
Yes.
So we will get to work, and you have the women of the Legislative Black Caucus on here. So rest assured, we'll be calling on you to be sure that the words make sense when we write the legislation and has impact. But we're committed to this work. And I want to thank each of you and your companies that you represent for truly taking time out of your day to share this information. It also will be uploaded to our website, so it will live with our partners as well. So thank you, thank you, thank you. Assemblywoman, I'm turning it back over to you.
Back over to me. Dr. Rogers, any parting words you have for us?
Unfortunately, of course. I want to actually go back for just a moment to what Damali was saying. Dr. Campbell, forgive me, although you're my colleague, so we're on a first name basis, about particularly maternal child health, and encourage us actually to be more willing to use the language around racism. Because both structural and personally mediated racism continue to be a problem, both in healthcare as well as outside of healthcare. And what we often do, particularly in a state as diverse as New Jersey, is we sort of clump people of color together. But people of color in this state actually do not have universally bad health outcomes. As a matter of fact, Asian populations have some of the best health outcomes and the greatest life expectancy of any group in this state. Hispanics and Blacks do not have equivalent health experiences. And so what we have to be willing to do is to talk about what it means to be Black in America and the adverse impact, not only of sort of decades of our own personal experiences with racism, but the decades and centuries long experience of racism that impacts what our lives are like. And I don't usually do this, but I'm going to put a plug in for Linda Villarosa's new book, Under the Skin, that really lays out this long legacy of racism and how it has adversely impacted our health. And I do this, Assemblywoman, with great respect, because I believe if we don't say the word, then we won't do the work to eliminate racism in our state and in this country. And quite frankly, we need to eliminate it in the world. Yeah. So those are my last words. Thank you for that.
Thank you. Thank you. Thank you. Thank you for the homework assignment. I love it. I love it. I feel like when you talk to good people, you always walk away with a list of things that you should be doing. So the good thing is, though, I do have a bill out for dentistry for pregnant women. So I'll ship that over to you because we're on the same path there. But universal health care is definitely something that we're going to be continue working on. Did I leave anyone out? And I don't. Dr. Campbell, did you speak already? If not, this is you have any final parting words?
I'm good. I think Andrew wanted to say something.
Okay, Andrew.
Yeah, I was just going to say you're breaking up, but I'll say something. I think just one little aspect that we did not talk about is that health equity is also quality care. right? Because we had struggled with that. You know, we look at quality care. You know, the IOM, I believe in 1999, was the one that came up with a framework that described what quality care is. If that care is safe, is it effective? Is it efficient? Is it patient-centered? Is it timely? And the sixth domain was equity care, but we never thought about that. Nobody looked at that because it was not the sexiest thing among all the domains. There was no money wrapped around that. So it's been considered a forgotten domain. So I'm really happy that we're at a stage now where we're bringing out a top of mind and we're talking about it and it's in vogue now. So hopefully, that will really let us address, as Dr. Rogers said, really the word that we really have to say, structural racism, you know, and how we can really give equitable care to everybody, just everybody. And once again, I really want to thank you all for the invitation. It was a great opportunity to learn from, you know, such talented panelists. Thank you.
Awesome. Assemblywoman Sumter, you want to close us out?
Absolutely. Thank you all. And I'm going to throw some homework back at Dr. Rogers. When we host in 2023, our Structural Racism in Healthcare series, you must commit to be a panelist for us on that session. So we got the thumbs up. You all heard it here first. So coming to you in 2023, we're going to take that deep dive. We're going to explain the differences and the structural racism within healthcare. And we're going to be unapologetic about it, but we're going to do it from the standpoint of action orientation. So we're excited about it and really thank you to Horizon. Thank you to RWJ. Thank you to Dr. Campbell, the New Jersey Medical Association, who's been our partner throughout the years. Thank you always to Dr. Denise Rogers, who's just a rock star and someone that I've followed for years. And understanding the space that we're called to work in this season and time. And thank you to each of you who joined as guests, because while we enjoy talking to each other, it's always good to have a listening audience. So we appreciate the support. And thank you to the incomparable Assemblywoman Verlena Reynolds Jackson from Mercer County from doing an awesome job. So Trenton represented. Everyone stay safe. Andrew, thank you for taking on this task with these powerful women. You held your own, and we appreciated you being in this space. Have a great day, everyone. Stay safe.
Thank you.